It is with great pleasure and an honor to introduce our keynote speaker. Dr. Kristi Pruiksma is an associate professor in the Department of Psychiatry and Behavioral Sciences at the University of Texas Health Center, San Antonio, and a licensed clinical psychologist. Dr. Pruiksma completed her clinical training and Ph.D. at the University of Tulsa. She works with the Strong Star Consortium and specializes in behavioral sleep medicine, cognitive behavioral therapy for nightmares and for insomnia, and cognitive processing therapy for post-traumatic stress disorder. She is currently funded by both the Department of Defense and the Federal Emergency Management Agency. She has published over 50 research articles and book chapters. So without further ado, I'd like to welcome Dr. Pruiksma as our keynote speaker.
So again, today is cognitive behavioral therapy for nightmares. And as we get started, I want to acknowledge others that have helped contribute to developing the slide deck and talk about the objectives for today. So first off, I want to describe normal sleep and dreaming, just very briefly. Again, sleep is its own field in and of itself, so that could be a full day talk, but we'll do some brief overview there. Identify some symptoms of nightmare disorder in the relation to post-traumatic stress disorder. And then also the biggest part, the meat and potatoes for today, is providing an overview of cognitive behavioral therapy for nightmares and some resources for additional training. I'm actually going to go ahead and talk about some of those resources here at the beginning, just because I want to make sure people have those just here at the start. I know sometimes people have to leave a little early and that kind of thing. So some resources that I do want to highlight, a couple of books that are available that can be helpful. There's a step-by-step program on overcoming sleep problems after trauma, and also the Treating Post-Trauma Nightmares book that has a whole treatment manual in it, and those are helpful. I also want to highlight that I am a co-developer with this DoD-funded cbtiweb.org. This is a free web-based provider training where people can log in from anywhere that you have internet and go through a training. It's 6.5 hours of required content with some additional content that you can watch as an option, like therapy vignette videos, like demonstrations and those kinds of things. So it's optional to get CEs for $65. And the reason why I'm talking about this is, well, nightmares and insomnia go hand in hand very much, but also we are excited that we have recently been able to add a module on nightmare disorder treatment. And so there's a whole lot more information there that again includes some therapy vignettes demonstrating some of the techniques. I almost was going to show some today, but I just didn't have enough time. I felt like so I really wanted to highlight this as a option. We're actually currently funded right now to build something similar that's all focused on CBT for nightmares. So that's a project that we're working on now. So hopefully will be available in the next couple of years. Now that I've showed you this resource, I do want to highlight a slight conflict of interest, potentially, that through this website, people can pay for CEs. Those proceeds are used to update and promote the web-based training, although I am a co-developer on that project. So I just want to highlight that potential conflict. So getting into more of the talk. Starting with normal sleep and dreaming. I think when we're thinking about people who have nightmares, we want to think about, okay, what is this showing up in? So nightmares kind of falls within within kind of trauma psychology, but also behavioral sleep medicine, which is just one part of sleep medicine. So So again, this is kind of this weird intersection of these different fields. And so I'm hoping to present a little bit from each of those to give the background that's important for helping patients. So starting out is that it's very helpful for us to understand that even though there's recommendations, oh, you got to get your 8 hours of sleep, a lot of handouts say, sleep 8 hours, that sleep is just like many other things. It goes on a bell curve. Saying that everybody needs to sleep 8 hours is kind of like saying that everybody needs to wear a size 8 shoe. It just doesn't really make sense. And so this graph is just showing here that most people sleep around 8 hours, the percent of the population. But there's some people who sleep less and do really well on less, and some people who need more and sleep well on more. This is important to recognize in that that one, individuals who maybe are struggling with insomnia and nightmares, or maybe have expectations of their sleep that maybe aren't so accurate, but also that people may be quite sleep deprived if they're having nightmares and getting much less sleep than what's recommended. So similar information, but presented in a different way. And I recognize that a lot of providers on this webinar maybe work with children or teens, young adults. So I did want to provide this as well. This is from the National Sleep Foundation. And there's a summary from 2015 on recommendations for amount of sleep. And this is the recommendation. So the blue with the ranges, the dark blue, is kind of the range of what's recommended. The teal color is what may be appropriate, and the orange is really not recommended for most people. And of course, this changes across the lifespan with toddlers needing more sleep than preschool and school age and teens. And in our society, it's more and more of a challenge to be able to even help the children be able to get an opportunities to sleep this long with school start times, practices for different things. And so this does kind of help us put into context the amount of sleep that is typically recommended. And then just a review, this might be familiar to a lot of people. When we think about sleep, it was like in the 1950s that they started realizing that there's different brain activity during different stages of sleep. Before, they didn't really know what the brain was doing, but they got the technology to have the electrodes and things. So 1950s really isn't that long ago. But this is when we started learning about these different sleep stages. So the first one, you can see it's very frenetic, very quick waves when we're awake. Stage 1, it starts to slow down. It's kind of that twilight zone where maybe you're kind of aware of what's happening, but sort of out of it. Stage 2, we're getting a little bit deeper sleep. You can see in the middle there's kind of these sleep spindles. That's kind of showing we're getting into deeper sleep. Stage 3 sleep, it's really slowing down. This is where our brain is really getting a chance to kind of do some slow processing. And then we move into that REM sleep, or rapid eye movement sleep. And if you're like me, you're probably getting, thinking about the band REM, The End of the World as We Know It song is probably in your head. And so, but that's just rapid eye movement sleep. We see that it almost looks like we're awake, but we're actually asleep. The body is calm. We actually lose muscle tone throughout the body, but the brain is very active. So this is really pertinent when we think about nightmares, because and REM sleep is where we get most of our dreaming happens. And REM dreams tend to be more vivid. They tend to be more story-like. But dreams can happen in different stages, but they tend to be a little bit like less vivid, a little more kind of abstract, random images, and less of a story. Later on, we're going to talk about how most people who are experiencing nightmares, a lot of it is coming from following a trauma. And there is some indication that trauma nightmares can happen at any stage and may interfere with us being able to get this rapid eye movement sleep. So we know REM sleep is really important for emotion processing, memory processing. We know that that our brain also prioritizes REM sleep. So if people are sleep deprived systematically, like in sleep lab, they're sleeping in a sleep lab multiple nights in a row and they're getting sleep deprived. Our brain prioritizes getting to REM sleep. Whenever we do get to catch up, it prioritizes getting to this REM sleep. So we know that that REM sleep is really important. We also know that when we're sleep deprived, they did a really interesting study where people learned lists of words. And not surprisingly, people who were sleep deprived couldn't remember as long of a list. However, if you looked at the emotional tone of the words in the list, the brain tended to remember the negative words to the same degree as people who weren't sleep deprived. But the people who were sleep deprived forgot more of the like emotional or positive or neutral toned words. So if you think about that, where we function best if we can remember some of the negative things that happen, because then we can avoid it in the future. It's kind of adaptive, it's survival. But you can also see how if that's how our brain is working and we're sleep deprived, people who have depression have kind of a filter maybe for some of the negative things and positive things just bounce off. So we see that sleep is really, really important for our emotional well-being. And this is showing how these different sleep stages are distributed across the night. So, so we kind of cycle, it's about a 90-minute cycle from being awake to going into that first stage of REM, which is shown in the yellow pieces on the graph. And you get more of the deep sleep early in the night, less so in the later in the night, and more REM sleep later on in the night. So again, a lot of that dreaming is kind of happening later on. But again, people with nightmares may have the nightmares earlier on, which is depriving them of some of that important REM sleep. So what's the deal with dreams, right? So you think about like Sigmund Freud did a lot of work in dreams, and we're still come a long way since then, but also still just don't really know a whole lot. It's kind of a tricky area. But we do know that most dreams have a negative tone to them. So contrary to like Walt Disney would say, follow your dreams and, having all this positivity to it, that usually they're kind of negative, that something bad's happening. We're in high school and we forgot to attend a class all year, so we might not graduate. I know in August, a lot of teachers start having dreams about showing up to school and not being ready, right? Like there's something that tends to happen negative in them, but they don't tend to be problematic. We do know that dreams play a role in healthy emotional processing as well. So normal, healthy dreaming. There are some studies that for people, if they were going through a divorce at the time, people who actually had dreams about the divorce that had some predictive value to how that they would be doing more positively later on once down the road. So it's kind of interesting that had a relationship there. One model of dreaming is the activation synthesis hypothesis, and this is the idea that our dreams are coming from bursts of nerve signals traveling from the brainstem throughout the cortex. And the brain synthesizes these kind of random nerve signals into making some kind of story. So our frontal lobe, the thinking part of the brain, is kind of shut off, but the rest of our brain is kind of firing off and sending off these different signals because it's doing emotional processing, memory processing. So our half asleep frontal lobe starts, let's see if we can put this together into some kind of story. And that's sort of why our dreams, a lot of times, they don't really make a lot of sense, but how they also maybe sometimes bring in elements of current things that's happening. I'm sure everybody has experienced that, where once you start thinking about a dream, you're like, oh yeah, I think this happened because this random person that I knew a long time ago showed up in my dream because I saw a post on Facebook and started thinking about them for the first time in a long time. something like that. One idea is an analogy is kind of that our brain sort of serves as a stained glass window, where the white light is coming in on one side and shows a pattern on the other. The brain acts as a filter to kind of impose some order on these random signals that are passing through it. And so dreams don't typically cause an awakening, though. They don't really typically cause problems, but whenever we're getting into nightmares, that's when problems are happening. And we're going to move into talking more about that. So talk about the prevalence of nightmares and the symptoms relation to post-traumatic stress disorder. So with children, we know that the prevalence increases throughout childhood into adolescence. So about 3.9% of parents report preschool children have nightmares. And occasional nightmares are very developmentally typical. Most kids have some nightmares from time to time. We're still learning why, but these don't tend to be a problem because they're not so frequent that it's causing consistent sleep deprivation. The prevalence increases from ages 10 to 13 for both males and females, and then continues to increase to ages 20 to 29 for females, while it decreases for males. And that's a pattern that continues, that women just tend to be more likely to be having nightmares. We don't really know why. Different theories out there about that. And it could be related to differences in trauma exposure as well. One piece of that. So if we're thinking about frequent nightmares, about 1% to 2% of the adult population have frequent nightmares at least once per week. But if you look at trauma exposed groups, whether or not they have PTSD, about 50 to 88%, so 50 to 90%, it just depends on the study, finds that these nightmares may occur frequently. And again, this could be part of PTSD or maybe it's not. But what we do know is that for individuals with PTSD, the sleep symptoms are often sticky. And what I mean by that is that we know that if people successfully treat PTSD, let's say they complete a course of prolonged exposure therapy or cognitive processing therapy or EMDR, and they are no longer meeting criteria for PTSD, they've resolved a lot of things in their trauma. For a lot of those individuals, the insomnia especially continues. And for about half of them, the nightmares will continue at a pretty frequent rate. Anger is the other symptom that tends to be kind of very sticky, that keeps going. And so we also know that these nightmares can be associated with poor clinical outcomes, greater substance use, cardiovascular disease, increased risk of suicide. In fact, nightmares and insomnia and suicide risk, there's something about all that connect that they very much go hand in hand. And all of this to show that treating the nightmares is important, and can really have make a change in people's quality of life. So with nightmares in the DSM-5 and the relationship to PTSD, nightmares are listed as one of the symptoms for PTSD. If you remember, there's 4 different clusters of symptoms: the avoidance, the intrusion, changes in thinking and mood, and the hyperarousal. So within the intrusion symptoms, we have, I'm putting quotes, recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic event or events. And so that doesn't necessarily say that the dreams have to cause awakening to fit as a PTSD symptom, whereas other people would argue that nightmares require awakening. It's actually kind of vague in the DSM. And I think the other kind of tricky thing with this symptom is that it's hard to know if something is it's related to a trauma or not. So for example, if an adult is having dreams about, being chased by a monster, how do we know if that is related to maybe child abuse that they experienced as a kid? where someone's chasing them. It's a little bit tricky to define that for sure. And I'm just noting here that in children, there may be frightening dreams without recognizable content as well. So in the DSM, there's also a whole section on sleep disorders. a lot of times we don't even quite get there in our training, and to really learn much about the sleep disorders, unfortunately. But there is a nightmare disorder contained in the DSM-5 as well, and that includes repeated occurrences of extended, extremely dysphoric, well-remembered dreams. So this really tends to be what differentiates nightmares from other nighttime occurrences that I'll talk about later. But these dreams usually involve some effort to avoid threat to survival, security, physical integrity. They generally occur during the second half of the sleep period, although a lot of times it's really hard for people to be able to even answer that. On awakening from the dreams, they rapidly become alert, oriented, they realize they're having a dream, and the sleep disturbance causes clinically significant distress or impairment. I just want to highlight here on the clinically significant impairment, and it's really interesting depending on the population you work with. So I work with a lot of service members who for them, either they might not really say, oh, I have the nightmares, but they don't really bother me. But once you start asking questions about it, they're happening frequently. They are interested in getting treatment, which tells me they are clinically significant. Or service members sometimes will also just say, oh, isn't it normal? Like most of the people I know have nightmares, and so not realizing that that's actually something that can be treated, I think can impact this clinically significant impairment. Now, DSM-5 also says that for nightmare disorder, is this, I can't remember the exact verbiage, but it's something about like, is it happening in the context of another mental health disorder? That's kind of the primary. Well, it's incredibly difficult to differentiate if nightmares are secondary to PTSD, or more and more there's encouragement to diagnose comorbid problems. This is the same for insomnia, that these sleep problems can be their own issue, and it's actually encouraged to really think about diagnosing both, especially because we know treating the PTSD doesn't always resolve the nightmares and insomnia, and so that's something to think about. It's really kind of hard to differentiate like what's primary, and DSM-5 even is kind of moving away from primary, secondary types of language. So I wish it was a really clear answer, but it's a little bit murky on how PTSD and nightmares go together. I also wanted to highlight that not everything that sounds like a nightmare is a nightmare. Nightmares can be related to PTSD, or trauma related, like we said, but also in the middle circle here, you can see nightmares can also be what's called idiopathic, where there's not a trauma, but somebody just has nightmares frequently. That's not really related to any certain pathology. But also in the circles around the middle gray one, I'm trying to highlight other things that may initially kind of sound like nightmares, but are actually different and need a different treatment, different assessment, different referrals potentially. So on the top there, anxiety dreams, bad dreams. So these tend to be those dreams that are really uncomfortable, but don't actually cause an awakening. Whereas nightmares, typically we think about them actually causing an awakening. Also nocturnal panic attacks. Somebody is waking up in the night, their body's activated, deep, quick breathing, heart racing, sweating, those kinds of things. But a nocturnal panic attack, it's happening kind of out of the blue. There's no clear reason, but with a nightmare, they might be having those kinds of physical experiences, but it's related to the dream content. Moving on down around the circle, sleep terrors. Somebody actually may sit up screaming, even walking around. It happens commonly in children, but they aren't actually awake. And if you try to wake them up, it's really hard to wake them up. They don't really remember any kind of dream content. They're confused about what's going on. which is different. Again, nightmares cause someone to wake up. They realize they were having a dream. They're oriented when they wake up. So sleep terrors, the idea is just to help guide the person back to bed without necessarily waking them up. It's more scary for the other people in the house than it is for the actual person experiencing it. Moving on around breathing related sleep disorders, so sleep apnea. A lot of, I'm guessing people are kind of familiar, but this is where there's an obstruction or just a central brain signaling problem that is leading to cessations of breathing multiple times during the night. Most of the time people kind of sleep through those, but sometimes people will wake up kind of gasping for air, which again might kind of feel like a nightmare. But if there's not dream content, then it wouldn't be a nightmare. And finally, REM sleep behavior disorder. This is where people actually act out their dreams. This is really typically more kind of in, it's related to different neurological disorders like Parkinson's disease. And so it's typically an older population, although not always. And there usually isn't, people don't wake up from that, but they're thrashing, they're doing complex motor movements during the night. Whereas in nightmares, people might move some, but there's not so much movement. So those are all different things that, again, breathing related sleep disorder, REM sleep behavior disorder would be more for a referral to a board certified sleep disorders clinic, because there's different assessment pieces that would need to happen to assess and treat those. So, we do know also that nightmares are underreported, therefore they go undetected and untreated. We don't really know why they're underreported. It's possible that people just don't really realize that there's treatment that can be done to help them. Like I said earlier, in some populations, people assume that it's normal, that most people around them have these nightmares. But this is why screening is recommended. There's a newly published nightmare disorder index that it is a brief 7-question item that's to be used as a screener, or if you are regularly kind of assessing trauma and PTSD types of symptoms, PCL-5 item 2 could be an initial screener, or even just asking, how often do you have disturbing dreams that wake you up? This very straightforward question could also be something to be integrated perhaps in like just baseline intake paperwork to be able to identify this. Again, sometimes people will just say, we'll bring up that they're having nightmares, but there's been some research that even people with clinically significant nightmares don't always bring them up. And that's something we're still trying to understand. So I'm hoping that has at least given an initial cover for nightmares and a relation to post-traumatic stress disorder. And now at this point, I'm going to go ahead and move on to talking about an overview of cognitive behavioral therapy for nightmares. Cognitive behavioral therapy for trauma nightmares is kind of what I'm focusing on. Now, there's some indication that these approaches could work with idiopathic nightmares as well. But there are a lot of different terms that are used in the literature for very kind of similar approaches. There's imagery rehearsal or imagery rehearsal therapy, exposure relaxation rescripting therapy. We're actually working right now to develop like kind of more of a consensus manual to kind of bring things together, because in the literature and the reviews, the evidence base gets kind of sparsed out in these sort of unhelpful ways when a lot of these approaches actually really overlap and are very similar. And we're using the term cognitive behavioral therapy as like an umbrella to kind of capture all of these different ones. So these approaches typically include some psychoeducation on sleep, on trauma. They also include, I'm going kind of from the left to the right here, sleep habit modification. So this is going to be things like stimulus control therapy, using the bed for sleep or sex only, not getting out of bed if awake for more than 15 minutes or so, different sleep habits as well. I'm not going to go into that as much today. My understanding is that Allison Harvey recently presented on CBTI, and so I don't want to overlap too much with some of that. But there's a lot of helpful, important pieces of sleep habit modification. And then also these manuals also oftentimes include some relaxation training, most often progressive muscle relaxation, diaphragmatic breathing. And I'm guessing that those are all familiar approaches for people, since those are kind of the aspirin of behavioral medicine. So what I'm focusing mostly on today are these other components: how you do exposure exercises to nightmare content, rescripting nightmare content, and then imagery rehearsal. So exposure is actually confronting the nightmare, writing it out, reading it out. Rescripting has to do with coming up with a new storyline for the dream, and then imagery rehearsal is imagining this new changed dream. And those are the pieces I'm going to talk through a little more detail today. But I do want to highlight that those pieces that are not circled, just those pieces alone have also been shown to reduce nightmare frequency and intensity. And so cognitive behavioral approach with all of these is kind of trying to just, it's like a shotgun approach, trying to just, let's give as many skills, as many tools that we can, because we don't know what works for who. And we want to equip patients with as many strategies as we can to help reduce their nightmares and improve their sleep. So again, I don't want to minimize those other pieces, but the exposure, the scripting, imagery rehearsal tend to be the more unique pieces that are new and different. So I'm going to talk about those a little bit more in detail. I find stories and learning, examples is a easy, very helpful way for learning something, especially new. And so what I'm going to do is I'm going to talk about a case study. And, I'll note that I'm going to share some parts of the trauma and some parts of the nightmares that can be, uncomfortable to hear, especially for some people. So I just kind of wanted to put that out there ahead of time. So this case study is a 27-year-old service member that I treated several years ago. I was white, a specialist in the Army. His MOS in the military was in infantry, and he had completed one deployment in Afghanistan. While he was deployed, he was sexually assaulted by members of the Afghan forces. So specifically, some context of that is helpful for understanding the nightmares I'm going to talk about later, was that one of the local interpreters that he knew asked him to come with him to meet with the commander. And instead, the interpreter led him to a building where he was assaulted by 6 members of the Afghan forces. He developed severe PTSD as a result, with nightmares about the assault almost every night. He gained a significant amount of weight. He started using alcohol regularly. And by the time he was referred to our clinic, this was at Fort Hood, he had gone through a substance abuse program and had become abstinent from alcohol, which I think says a lot about this patient, because he was already able to make that kind of big change even before treating the PTSD. And so I saw him initially for cognitive processing therapy. And this graph is showing how he did in cognitive processing therapy. So the orange line is from the PCLS, so the PTSD tracker from the old DSM, going from about a 65, it dropped down to about a 30, whereas I think it was about, a 17 was the lowest you could even get, because the anchors started with a 1. If that makes any sense. So a significant reduction with pretty few PTSD symptoms remaining. And then the blue line is the BDI, the Beck Depression Inventory. So we also see some improvements there. I'll highlight on the bottom axis that between session 10 and 11, he actually went to an inpatient program for a couple of weeks. He had the opportunity to participate in this program that was for sexual assault survivors. And so he was able to be in groups with and meet other people. And so he even though he was doing really well in treatment, he opted to take up that opportunity, and he found that to be helpful. And then when he got back, we went ahead and finished the CPT protocol, and we were reflecting on the changes and the improvements, and then he, kind of offhand comment said, I'll just have to get used to these nightmares I'm having every night. And which of course for me that, made me notice, and I caught my attention. And so we decided to do a few sessions focused on his sleep. So in session 1, we did an overview of treatment, worked on some sleep habit modifications. So again, that's stimulus control and some sleep hygiene, which are 2 different things. I'll highlight, people get them mixed up a lot, but it's 2 very different things. And then we also taught progressive muscle relaxation, how to start practicing the PMR. Session 2, we did psychoeducation about trauma and nightmares in the relationship, and taught a second progressive muscle relaxation. The idea with the relaxation exercises for nightmares is we want to just reduce that physical activation, that hyperarousal that people experience, during the day, at bedtime, during awakenings. And so we provide a couple of different scripts so that they hopefully can find something that they like, or just be able to change it up from time to time. And then in session 3 is when we engage in the nightmare exposure and the nightmare description. And then we also teach diaphragmatic breathing and image rehearsal as well. So I'm going to talk more about session 3 in detail. So the idea for the nightmare exposure is that, just similar to other exposure-based therapies for PTSD or anxiety or phobias, is avoiding things that are feared tends to not be helpful, and actually can keep the problem going over the long term. And so by actually approaching rather than avoiding the nightmare content in a safe and supportive environment, the idea is that can take some of the power away from the nightmares. And so in this protocol, we actually have the patient choose which nightmare they want to focus on. So some people have a lot of different nightmares. The nightmare is a little bit different every night. Some people have like the same nightmare over and over. You can use this type of approach, with a range of nightmare presentations. But what you want to do is, in the box to the right here, we want to pick the dream that's the most disturbing, or the most recurrent, or the most recent. But the idea being that, while the person's in therapy, let's approach the hardest one together where they've got the support. And we also tend to see that focusing on the worst one typically helps reduce maybe the less worst ones as well. And, but also it's possible to set up the treatment to be able to focus on more than one nightmare at a time, or to focus on one and then focus on other ones as well. So this is what differentiates this approach. Some of the nightmare treatment protocols would go for a less intense one first. But the idea is to have the patient in the session write in first person. So like, I am going down the road instead of I went down the road. And in present tense, as much sensory detail as possible, and to not leave out any important pieces. And we also have patients do a SUDS rating before and after. So on a scale from 0 to 100, 0 being very relaxed, 100 being very stressed throughout your body, how are you feeling before and after writing the nightmare, and, before and after each of these different pieces. So I'm going to talk about, we presented these guidelines. The patient was able to identify which nightmare he wanted to focus on first, and I'm going to read that nightmare to you now. This was the original nightmare. It is late, but the moon is full and gives a strange cold glow to the night. I watch myself walking with an interpreter. I'm terrified, but it does not show on my face. My body and mind are disconnected. My mind left to drift above myself, set to watch helplessly. I know that I'm walking into an ambush. What will happen if I go further, but I keep going? I fight each step, but like a machine, continue. I walk through rows of Afghan barracks, coming to a halt in front of their command building. We walk inside and the smell of cooked beef liver and unwashed bodies assaults me. It is dark inside, except for the room to our right, which we enter. I feel my heart beating through my chest. I tell myself to leave, to run, but my face shows none of my concern. The room's walls just melt away, and I'm under a light surrounded by bearded men with no faces. Still, I go to warmly embrace them. I feel the blow before it even lands. It hits me in the left side, and the light goes out. So you can see that this is very detailed. It's very vivid. I mean, just reading this, I feel a little stressed, a little scared, and that's the idea. We want it to be really activating kind of that fear network to get a lot of details of this dream. And then the next step, is to identify different trauma-related themes that are within this nightmare. So if you are familiar with cognitive processing therapy, these probably sound familiar because it's exactly where these themes came from. Power and control, safety, trust, esteem, and intimacy. And so I think a lot of times multiple of these themes can show up in the dream. And, for this one, I think it was definitely safety. He was unsafe. But also esteem. He's telling himself, stop, what are you doing? Don't go. So esteem for himself, and then also esteem for these other people. These bearded men, they don't have their faces. And also power and control, where in his dream, he's seeing what's about to happen, but he's telling himself stop, and he has no control over his actions. So the idea is we have the patient identify maybe the top 1, 2 to 3 themes in the dream, and we're going to use this in the next step for rescription. So the idea with rescripting the dream, and you can do this either in the same session if you have a 90-minute session time frame, or you can give them the instructions to think about ways that you might rescript, and then at the next session actually sit down to do the rescription. Is that we want to have them follow the same guidelines, write in as much detail as possible, write in present tense. But the idea is to focus on these themes and changing these themes on their head. So if there's not much safety, increase the safety. If you're having no power and control in the dream, what can you do to give yourself some power and control? And we found that people kind of taking an active role in addressing and flipping these themes tends to be the most effective. And people can rescript in a lot of different ways. They might rescript the beginning, the middle, the end. They might use humor. They might give themselves superpowers. They might, for dreams where maybe somebody has died and it feels kind of wrong to change things, maybe the dream is some way of being able to honor or grieve for that person. So there's a lot of different ways you can approach this. I can't go into too much detail today, but I want to present the first prescription that my patient came up with. And just kind of to start out, you can see that this first prescription was, maybe he's kind of skeptical about what was going on. It's kind of, okay, good lady, whatever, it's a little bit crazy. But here's what he wrote the first time. It's late and I'm walking with an interpreter. The moon gives a strange cold glow to the buildings around us. The moon's rays begin to give a transparency to the walls until they slowly begin to melt away. The barracks are now just blocks of cement with confused Afghans perched on top. It rains candy. There's also a dragon. I ride it. It's a Falcor from the movie The Never-Ending Story. Wishes are made. The day is saved. G.I. Joe. So when he wrote this, I remember thinking, okay, I'm not so sure about this. It seems a little bit skeptical. That's okay. That's kind of a wacky, different kind of approach. Let's just see what happens. I wanted the prescription to come from him, from the patient. I couldn't do this for him. And so I gave him the guidelines for imagery rehearsal, which are every night to close his eyes, practice 5 or 10 minutes of just imagining this new dream. So the idea with the prescription and the imagery rehearsal is that we're just kind of giving the brain a different route to go down. So it's kind of like if you think about like a truck with going down up and down a muddy road. it's going to be very entrenched, and we're trying to give like an exit. We're building a new path to have something, a different direction to go down. So told him to practice the imagery rehearsal. He did it only a couple of times, and he comes back to session 4 and was saying, you know what? I had like a weird abstract dream for the first time since I don't know when. It wasn't a vivid nightmare. So, okay, maybe there's something to this. Maybe something's going on. So we decided, all right, let's work on this prescription. Let's write something maybe a little more powerful, a little stronger. And this is what he wrote the second time. The moon casts an eerie glow. I'm walking in the Afghan barracks. I feel the crunch of sand beneath my feet, but do not control my steps. I look around me. I've been here. I know I'm walking into an ambush. I look down and see myself take each step against my own command. I have to take back control. I concentrate on my senses, feeling each footfall, the sway of my arms, the earthly smell of dust, the cool of the night. If I can feel these things, then I am here. If I am here, then I can have control. I come to a stop. This is different. I clench and open my hands at my discretion. The interpreter notices the change. This demon would guide me to doom each night. He charges me, but I do not fear him. This is now my dream. I reach a hand out and his attack falls short, leaving him suspended in the air. I leave him there. I looked at the sky and I call for the end of the night. The sun rises, the buildings crumble to dust, then the mountains. Grass sprouts up, followed by massive trees, and a stream rushes past and into existence. I sit here and I know I'm safe. So way different, right, than that first prescription, and a very powerful one. You can imagine, you can see these themes, you feel different, right? He's kind of primed himself to have very different emotions during the night. And so that's what he wrote. So session 5, we review the practice, problem solve, we do some relapse prevention, but I want to show you, so this is the graphs for his outcomes. But before starting CPT, before any treatment, he was having 7 nights of nightmares a night, and that continued after CPT treatment. Every night he was still having nightmares. After we focused on these nightmare treatment, he reduced to only having 1 nightmare in the previous week when we did this assessment. His nightmare severity, 4 before treatment, 2 after, and a 1, or I think 4 was the highest you could get. Hours of sleep per night, he was only getting 4 hours before PTSD treatment. Improved significantly with PTSD treatment, and we were able to add another hour, which is very meaningful. And now a whole another hour of sleep is very meaningful increase. And we saw similar progress on his other outcomes, from 65 on the PCL down to 29 after PTSD treatment. We got that even lower. This is the PTSD interview, similar pattern. Depression, similar pattern. So with just a couple more sessions, we can see that we were able to improve and make some changes there that were meaningful to help alleviate these nightmares here at the end. So I think that is to the point where I'm going to take a pause and we can kind of pivot into the Q&A section. One of the things that I know a lot of people on this call actually work with young adults and children. So most of the nightmare treatment research has been done in individuals who are 18 or older. A lot of that is just simply because there's different IRB implications for working with adults versus children, and so we do think that probably this type of work can be done very similar to for people younger than 18. And fortunately, we have one of my colleagues that I actually went to grad school with, Chantel Fernandez. She is a psychologist who works at Tripler. She's actually available and during this panel discussion is going to also talk about some more adaptations for children. I have some slides for her, and Chantel, I don't know if you're on yet, to switch to the panelist mode. Well,
yes,
I'm sorry?
I said, hi, I'm on.
Hi,
Hello.
Chantel. So I have some slides, and I can just advance the slides. I'm guessing in the Q&A that this is one of the main questions. So we're going to go ahead and answer those questions about adaptations for children. And so I'll just advance the slides for you, and you can tell me when you're ready for me to switch them.
Okay, great.
Okay.
All right, can go ahead. All right, so I can talk about some of the modifications that were made. So actually, ERTC is what we used to call it, was initially modified for children all the way back in 2007. Was when we first started doing this research. It was actually a part of my dissertation, and this work has continued on with Dr. Lisa Cromer has continued to facilitate this research with her students over in at the University of Tulsa. And there's been some work from the University of Montana as well with the child treatment. When we first did the initial modifications or adaptations to children, we kept it pretty similar to the original treatment from Joanne Davis. And so the modifications at that time to the treatment included just utilizing more developmentally appropriate language. So the language was modified. We also included additional manuals. So this is from the very beginning of time. So we wrote a parent manual, we wrote out therapist manuals along with child manuals, and we also included a lot more activities for the kids to make it a lot more fun. We included a lot of coping skills in this initial revision to include things like squeezing lemons and, for progressive muscle relaxation and just adding a bunch of those different things. And one of the biggest changes that occurred was in the exposure piece of things. So when we're doing exposure with the children, we left it up to the kids and like how they wanted to do that. There were some kids who wanted to write about their nightmare and their scripted nightmare. There were others who drew, and the therapist served as more like a secretary, similar to TFCBT, and wrote out the nightmare for the kids and read the nightmares to the children and then assisted with the description. There was actually a paper that we published many years ago. It was on a case series. And we'll talk about that just a little bit later. But following that case series, we made additional modifications. We learned a lot from that initial study. So there were a lot of things that we learned that we had to do differently. It wasn't working exactly in the same manner, although we were finding, positive results. We were seeing, nights with nightmares going down. We were seeing improvements in sleep, improvements in behavior. But we realized at that time that we needed to extend things out a little bit more. We needed to work with the families more on like additional strategies for dealing with other types of sleep problems, like kids refusing to go to bed or not staying in bed. So those were some additional things we saw, and we thought, okay, we need to add on an additional session. We need further parent involvement. And so we continued on. And so now the way the treatment looks, it includes a lot more, it's just gotten a lot more fun. It is, from where it was before. And I really enjoyed to take part in this and to see the progression of this over the years. Some of the things that have changed is there's instilling hope is a big part of the first session of the treatment. And this was added in because I think in the beginning, we talked a lot about all of the problems that could occur from poor sleep and nightmares. And we didn't really have something in there for instilling hope for the families and the kids. So instead of talking about, how grades can go down and, there could be health problems, and, we started talking about what can change. So once we start improving, our sleep improves, there are fewer nightmares, grades go up, and, it can help with, our attention and focus. And so just a lot more focus on those types of things. And there's an activity that's included on there for, what would look different, how would things change? And just having the kids focus on that. There's some other things, some other activities for relaxation, for example, or sleep. Let's talk about relaxation. So for the relaxation, not only are we having them listen to scripts, we're giving them little lemons to squeeze, to help with their relaxation. Some other things for sleep habit modification. So we're working a lot on sleep hygiene, and it's very similar to what we're doing with the adult treatment. But there's some other fun activities that have been included, like stimulus control. So the picture that's added here is actually like a pillow activity where the kids they draw a picture of something that helps remind them, okay, like this is what's supposed to be happening, this is my bed, this is my pillow, this is where the sleep is supposed to occur at this time and in this area. So it's just a fun activity for the kids. And then the exposure to nightmares, as I mentioned, so the drawing, the talking, and the writing, and really working with the parents on how to assist their child at home, and so those are some of the biggest modifications that have occurred, and just further rewriting of all of the manuals over time. And it's still younger in its infancy, and we're still currently doing research on this. But you can go ahead, you can move the slides up. Okay, so this is an example of, similar to, some of the other slides are presented for the adults. This is an example for how we would go about rescripting a nightmare that a child is experiencing. So I'll go ahead and read this example from this child. So I am in my room when I hear unfamiliar noises downstairs. I think it's my parents downstairs talking. So I get out of bed and peek down the staircase to investigate. I see a scary stranger in all black in the kitchen. The stranger sees me and turns to come up the stairs. I sprint to my parents' room to wake them up. But when I get there, the room is empty. So this is the original nightmare here. And so you can go ahead and along to the next slide. So as it was mentioned, right, a big part of looking at this original nightmare is identifying the themes. And sorry, can we go back to that one really quickly again?
Okay.
About that. So, so looking at those themes, of safety and, all of those things. So now we assist and help them out by going ahead and doing the rescripting. So I'll read the rescripted nightmare by the child. So you can see the areas in green. This is where it was rescripted. And so of course we want to keep it as close to the original nightmare, but really focusing in on those themes so that the person can have those, the theme here that was recognized as safety, so that regaining that safety. So I'm in my room when I hear unfamiliar noises downstairs. I think it's my parents downstairs talking. So I get out of bed and peek down the staircase to investigate. I see a scary stranger in all black in the kitchen. The stranger sees me and turns to come up the stairs, but the stairs turn into a down escalator and the stranger can't get up. Then the stranger's coat gets stuck in the escalator steps and she falls and bangs her head and doesn't move. I sprint to my parents' room to wake them up, but when I get there, the room is empty. I call 911 from the phone in the room, and the police come and tie up the stranger and take her away. Mom and dad were tied up in the living room and the police rescued them and we were all okay. So you can see how that really fits that theme of safety. So the child has rewritten their nightmares so that they now have a sense of safety. And then of course, as the homework would be to visualize that, or to have a parent, what we had the parents do is to read this rescripted nightmare to the child, and the child to visualize while that reading of the rescripted nightmare. We always want to make sure it's the rescripted nightmare that is, imagined or discussed before bedtime. So that's just kind of an example there for a child one. It's really interesting to see how the kids decide to rescript. And, I can think of one that where it was a home invasion, and, instead of the person who came into the home, instead of taking out a gun, when he tried to pull out his gun, instead it was a large Scooby snack, so like fun things like that. And he was wearing a tutu, and instead of being scared, the child was able to laugh while he was tripping over his tutu running out the door, so those are some interesting ways that kids will rescript things and still, stay close to the original enough. So we say that because if they rescript it too far away from the original, we see less of effect on the changes in terms of the nightmares. And for the case series, we did have that, for one of the original investigation that we did with the kids, we did have one where we had to continue to further modify, the prescription because it was too far from the original. And so what we saw was that after the prescription was closer to the original nightmare, that we saw continued improvement over a longer period of time. So, okay, we can go on to the next. Yeah, and so the promising results, for the children for this adaptation. So as I mentioned, that there is a case series, that was our article in 2013, looking at the original modification to ERT. And so Cromer and colleagues in 2020, they further adapted this treatment for kids for ages 5 to 17. And, they found, let me go back to the first one. So what did we find? We found that a reduction in nightmares, PTSD severity, sleep disturbances, and behavioral problems. And again, this was a case series. And, so we just went through case by case. And these are some of the things that we saw was promising. And we just wanted to continue on with our work to see what we had here. And then Cromer and colleagues, as I mentioned, pilot study. So it was a much larger study using the same treatment, and they found improvements in nightmare frequency and distress. And they were able to take a look. This was my original. This is really what I wanted to do, but I was not able to. I just didn't have a large enough sample at the time, but they were able to follow up, and 3 and 6 month follow-ups, and revealed that nightmare distress continued to improve. 6 month follow-up, and nightmare frequency improvements were maintained in 6 months. And then most recently, and this is what we started understanding was happening, but we're looking more at it now, is that we're seeing that this treatment can also help with, other types like idiopathic nightmares and other types of sleep disturbances. And that what was found is in 2022. So we're seeing that as well. So not only does it help with post-traumatic stress nightmares, but post-trauma nightmares, but also those idiopathic nightmares. So, and I think that's it for those sections there. Thank you.
Thank you so much, Chantel.
Yeah.
And so I'm stopping sharing my screen. And Chantel, don't go away, because I think there's some questions that you might be able to help answer too with the children. So Brad, at this point, should I just take a look at the Q&A? Or
Yes, thank you. So Kristi, is that kind of finishing up the formal that was stellar. Thank you so much. Yeah, so it would be great if we could kind of maybe pivot to the Q&A part. As you're suggesting, we have a mix of questions coming in from the chat as well as from the formal Q&A. So I'll do my best to kind of recollect as the sequence in which they came in. I know I'm going to get it wrong, but I'm under the impression that first question came in from the chat from Judith White. How are REM sleep behavior disorder? How's REM sleep behavior disorder and night terrors different? That's the first question.
Yeah, I think it's a pretty different pathology. So sleep terrors aren't necessarily like acting out a dream. That they're not really having a dream. They're getting up, they're walking, they're screaming, they're having these physiological behaviors. And it's, again, that's usually more in children. And then REM behavior sleep disorder is typically more like in older adults. And it's a different pathophysiology. I mean, I think that's an interesting point, that they do sound very similar. But it does tend to be pretty it's a different, trying to think of the other diagnostic pieces that are different. I think with REM sleep behavior disorder, a lot of times there is a dream that's kind of remembered. And if somebody's woken up during that, they kind of get alerted, oriented. But with REM sleep or with sleep terrors, that's not the case. They're really hard to wake up. They're just confused. They don't remember anything happening.
Thank you very much. Go
There's
ahead. I'm sorry, Jane.
there's a comedian that has that disorder, the REM, like where he acts. Is that what it is, where you're acting out your dreams? And his name's Mike Robiglia. I cannot spell it. But he gives a really good description of what it's like to have that sleep disorder. So if people are interested in it, he does a lot of like comedy routines, not to make light of the disorder, but he has it and he kind of talks about what his experience is like.
Oh, thanks for sharing that. That would be interesting to see.
Yeah.
Thank you, Jamie. Yeah, so we're looking, Kristi, if you look at the bottom of the Zoom interface, the Q&A part, if you click on that now, maybe that might be kind of the way to go. Yeah, so I'll just read them in order. Also you can read them, but I'm not too sure if everybody in the audience can see them, but I'll just kind of read them out, and then maybe after I read them out loud, Kristi, if you could kind of tackle them one at a time. So coming in first in the Q&A, CBTI and CBTN seem quite similar. What are the differences?
Yeah. So I would say that CBTI, again, is the first line recommended treatment, even above medications, for insomnia when people are having trouble falling and staying asleep. And I'm a big proponent of any kind of nightmare intervention building on to CBTI, because we know that insomnia and nightmares often go hand in hand. And so I think incorporating some of those important elements of CBTI are important. The CBTN pieces, I think, that are different is going to be the exposure and rescripting of the nightmare content. I also think it's really important, it's very different case conceptualization. So somebody with insomnia, a lot of times they're really worried that they're not getting enough sleep. They're saying, oh, I got to get more sleep to function. I needed my 8 hours. They're having a lot of unhelpful thoughts that are kind of like that. But with people with nightmares and maybe who've experienced trauma, it looks very different, where they're afraid to sleep. So instead of being obsessed with getting more sleep, they're maybe afraid to sleep because they don't want to have the nightmares. And so there's more of a fear component to it. So I think that kind of changes how you're going to conceptualize and approach the intervention. But I think the nightmare treatments, building on to what we also know is really helpful for insomnia, that there is a lot of overlap, and that's by design.
Thank you so much, Kristi. Moving on to the next one, CBTI appears to be the best supported approach for a variety of sleep-related concerns for children and adolescents. What are some nuances for addressing concerns related to nightmares versus night terrors via CBTI? For example, would exposure be appropriate for night terrors?
So I hopefully, I think some of what I just said is part of those nuances that I think are really important that can come up. Let's see. Exposure, I don't think really would be appropriate for the night terrors. Night terrors, again, there's usually not really like a dream content. And so you really wouldn't necessarily have something to work with for night terrors. I think usually kind of the intervention is psychoeducation about, what's happening. And encouraging other people in the household to not try to wake up the person who's having the night terrors, but to help just kind of guide them back to bed, maybe setting up the environment to be a safe environment. If the person, if there's like sharp corners from a dresser that's really close to the bed, maybe putting some padding around that, or, something like that, so that if they're, moving around a lot in their sleep, they're not going to hurt themselves. But yeah, I think it is a pretty different kind of set of how you would do intervention for that.
Thank you, Kristi. Third question, I'm just going down the list in the Q&A, and then we'll go back to one last question in the chat so far. The third question, how do symptoms such as sleepwalking, for instance, sleep eating, sleep driving, etc., fit into the paradigm of idiopathic trauma-related nightmares?
Yeah. I think they certainly could be something else that sort of overlaps with, and they can also be comorbid as well. I mean, that's the thing with a lot of sleep disorders. A lot of times they don't present alone. But I think again, that big differential is their dream content. A lot of times with the sleep eating and the sleep driving, there's actually not necessarily even dream content that's going on with those. Those are just behaviors that are happening that the person doesn't wake up from them either, but they might notice that something, the next day happened or somebody else around tells them what happened. So I think that that's a big differential that I clinically haven't seen come up very often, and that I haven't seen people kind of get them mixed up with nightmares as much either. Those I think tend to be a little bit more like straightforward on like, whoa, this happened to me, that somebody told me the next day, or I noticed that some of my food was gone from my fridge, but less to get kind of mixed up with the nightmares.
Yeah, we do see. So I was just gonna.
Please do.
Yeah. So some of the literature that I came across on some of that is like oftentimes for like those kinds of problems that you tend to see, there's a genetic component there, and then there's also a big piece in which it's related to how if someone is very tired, experience a lot that day, let's say for a child, if they had soccer and then right after that they had swimming, and then so we tend to see a lot more of those kinds of problems occurring during those times. And also I think that there's some information about it occurring at a different time, like during sleep as well. So just wanted to throw that in as well.
Yeah. So while you were talking, Chantal, I had a chance to kind of look at the Q&A, and I wondered if you could talk about, I think we kind of covered the next one, but the one from Susan Rocco about should you be treating a child who is nonverbal and are unable to clearly describe his or her nightmare? I'm curious to hear what you would say to that.
Okay, that's a let me try and answer that one actually. So in a lot of in the studies that we did, we worked with children that were able to describe, like an older age, and who were able to describe the nightmare so that we could talk about it in order to skip that. So that would be challenging. One of the things, if I were to do this, let's say, if I was trying to do this in session with a family, is possibly if the child could draw, and I would have the child drawing out the nightmares and trying to understand what it is. And the parent could ask the questions like what it is and trying to guess at it, and then work with the child on trying to change it to maybe just even in general, making it more positive, because it would be difficult to, if you could find a theme, or if you're with a therapist, working on that to make those changes, but it's not as clear cut. There's a lot in the literature also with just pediatric, just like for idiopathic nightmares, about the use and benefit to letting a child know that they were okay and that, the nightmares are not real, and just a lot of that reassurance. So I would probably turn to some of that to assist that child, because it really isn't, we have not looked at this treatment for kids who are nonverbal, but I could imagine that those strategies would also be helpful, just lots of reassurance. And yeah, I hope that helps. That's the best I can do for that one.
Yeah, thank you.
Mm-hmm.
Thank you, Shan. Thanks, Kristi. Continuing on, maybe one more in the Q&A, and then we got one more in the chat. But the Q&A, official Q&A, what is the treatment progress / outcome monitoring methodology? Your you referenced for your nightmare disorder. Sorry, I'm probably butchering
Yeah,
that.
I didn't have, again, I really hope if people are really interested, right, this is definitely not enough to like go run out and start treating patients. So I really do hope that you can seek out some further learning, because I didn't really have a chance to talk a whole lot about assessment. There are several different nightmare treatment, nightmare assessment measures. One that we use a lot is called the Trauma-Related Nightmare Survey. There's another one called the DDNSI, the Disturbing Dreams and Nightmare Severity Index, I think. But also a sleep log. For people who are familiar with CBTI, right, that sleep diary, that sleep log is a really, really critical component. And we have one where we just modified it to also ask about nightmare frequency, nightmare severity, and to prospectively, have people monitor their nightmares along the way during treatment. Super, super helpful, super informative, as well. They're also going to be writing down when they're going to bed, how many times they woke up, those kinds of things. And so those are all different resources that we would recommend for monitoring. And I'm also glad you asked this, because I do think monitoring is super critical and important for most of the evidence-based treatments, right? And so this is something that we review at the beginning of sessions, make sure people are able to do. So thank you for that question.
I don't know if you've ever used any of these, but there are apps to like track your sleep and your sleep quality and nightmares and things like that. And I've used that in sessions with clients. Is that something that you use, any of those like apps that?
Yeah, I think that I've not found one that I've loved that has been like really user friendly quite yet, where you can like share the data with the therapist easily, right, and that kind of thing. But I absolutely, if that's what's going to help a patient actually be able to monitor and being paying attention to their behaviors, I think it is really, really helpful to use. And I think there's more and more coming out that I've not used yet. There's one, Sleep Space has one now. There's also a group called Adherely, where they make a lot of tools for a lot of different treatments for helping people be more adherent to these evidence-based treatments. And they have a new nightmare, or not nightmare, but at least a sleep diary app available. I don't know if it has nightmares, but yeah, there's Insomnia Coach, which is by the VA. That's supposed to go along with doing CBT for insomnia. And I've heard that one they've made to where you can transfer the therapist a little easier recently. So it used to be CBTI Coach, but now it's Insomnia Coach. Anyhow, I mean, I don't know if you know of other ones that I should check out. So I don't have one that I'm like, hey, you should use this, I recommend it. I think in general, if people are, if they have an Aura Ring or Fitbit and can bring, I think it's helpful. But I also think it's important that, kind of part of the therapy is them tracking and them thinking about their behaviors around sleep, that we don't want to lose by just passive tracking with the wearable. It's kind of a tricky area right now. I also think people like tracking, with their Aura Ring or whatever, or it can create insomnia because people are thinking, oh, I'm not getting enough sleep. And, like it can be causing more problems too. So it's, it just depends on the patient, I suppose. So thank you for mentioning that, because it is definitely very common, more and more these days.
Thank you very much.
Thank you for the wonderful presentation. I just wanted to jump in with two quick thoughts. One is that I really appreciate you kind of differentiating between the various different kind of things that can go wrong during sleep, right? And you were talking about the sleep behavior disorders, and I know some people were asking questions about that. I appreciate that you kind of highlighted a little bit more physiological nature of things kind of going wrong with sleep behavior problems. And I just recommend that if folks are seeing any clients that are having those types of issues, I would recommend to get kind of a medical exam and have someone also take a close look at like what medications maybe the patient is taking, because sometimes those things can cause sleep behavior issues. And then on the topic of medication, from my point of view, I would recognize, I think, like what you were saying, that the CBT-I and CBT-N are probably the first line best treatment, gold standard, and probably especially for children. But also, I think it's important to recognize that in some like real world scenarios, it's going to be difficult to treat some children with that type of treatment. And I'm just thinking from my own experience, my last time doing any kind of direct service with kids was in the youth prison. And that was a particularly hard place to do any kind of sleep hygiene or all kinds of parts of that kind of protocol. And so we did rely on medication sometimes to try to help fill some voids. And I just want people to know that there are medications that psychiatrists do use to treat nightmares. And I don't think those should be first line necessarily, but in some instances, they kind of end up being things that we do, I think, want to offer patients because they're not going to be able to participate in some kind of treatment protocol like what you're describing. So those were my comments, but thank you for that excellent presentation.
Thank you.
All right, just kind of rounding out the bases. One more question, and then I'll end with a housekeeping thing on the CEUs. So last question of the day from the chat from June Ching: how do parents assist the children at home? I think Shan spoke a little bit about this, but I'll turn it back to her for the last question on this for today.
Sure. Yeah, I can talk about a couple of things. One of the big parts is that, the parents are getting the same information as the kids. And so they are receiving the information, the psychoeducation pieces, all about nightmares and trauma and about sleep and all of those kinds of things. So if any kind of questions come up, from their children, that they can better answer those questions because they've also learned the same thing. Also for sleep hygiene, they play a big role in a lot of the recommendations and things that they're helping their child come up with the list of the things that what are the things that they're doing that are unhelpful at home for sleep, and what are things that are helpful, and helping to pick each week one of those things that gets modified. And sometimes parents don't realize that having a TV on at night could potentially be interfering with sleep, or the temperature of the room, those kinds of things. Or so that's what a big thing that the parents can do, so they can help with those modifications to sleep problems. They can also help their child, with their relaxation skills. So if they are utilizing a script, that they can help play the script for their child, or, throughout the day, to help solidify those skills, that they could help them in using those skills. What else? So just a lot of those different things. They can do the breathing with them. They can remind them when it's time to practice and encourage them to do that practice. So I hope that helps to visualize some of the ways that parents can be involved.
Thanks so much, Shan. So just two quick announcements. Friendly reminder, what we said in the beginning, in terms of CEUs, whichever email you use to register for today's roundtable, please be on the lookout for the feedback survey that is needed along with today's attendance. CEUs for both social work and psychology in special part, and due all thanks to co-sponsorship with both Hawaii Child and Adolescent Mental Health Division, as well as the Hawaii Psychological Association. And in final comment notes, just very, very deeply grateful for Dr. Pruiksma and Dr. Fernandez-Lopez presenting today. So thank you very much. That brings us to a close. Okay, thank you. Panelists, if you're free to hang out for a couple of minutes, that'd be great. But if not, no worries. And I think people can sign off now. Have a great day. Thanks everyone.
Sweet dreams.
Yeah. Thanks so much for being here. That's great. That was really good.
Thank you.